Shavania,
Hi Shane.
how's it going?
Good. How are you?
Well, thank you. You
Hey.
should be able to share your screen now. I have made you co-host.
Okay, awesome. Let me try. Can you see my screen now?
Yes, we can see that.
Okay.
Perfect. All right, so we'll just wait a bit and start just after 3.
Okay, cool.
Alrighty. Good afternoon, everyone. Welcome to this week's CPD. Our presenter today will be Dr. Ragavan. Shavania, I think we could perhaps just give it 3 more minutes and then we'll get started. I see there are still some people joining, if that's okay with you.
Yeah, sure. I think we'll give them a few more minutes.
Okay, sure.
Cool.
All right, good afternoon and welcome again. My name is Shane Murphy. I'll be filling in for Prof. Musu, who's presenting at the Wonka conference today. Today, Dr. Ragavan will be discussing dermatological conditions in primary healthcare. Dr. Ragavan is currently a family medicine registrar within the Joburg Metro District. Super smart and doing really well in the program. So looking forward to this discussion. We will have an interactive discussion, so please do feel free to either raise your hand or type in the chat box. And then Dr. Ragavan, then over to you.
Thanks, Shane, for a excellent introduction.
No pressure.
I'm not sure, are we still having the polls? I just wanted to ask you.
I think go with your presentation, and then what we'll do is integrate the polls into the presentation.
Okay, awesome.
That's all right. I'll upload them in the meantime.
Okay, thanks. Thanks a lot.
Sure.
Hey. Okay, good afternoon, everybody. My name is Dr. Ragavan, as Shane has mentioned. Thank you so much for joining, and I hope you have a good session and you take a lot out of this. Just going a bit into the contents of the presentation. I just want to run through a bit of terminology with you guys, a bit of common pediatric conditions. We're going to also be looking at the adult dermatological conditions, any allergic skin conditions, infectious skin conditions, autoimmune. We're also going to be looking at some hair conditions and nail conditions that are commonly seen in PHC. There are a few conditions that I haven't touched on in this presentation, primarily because we are short of time. Hopefully we can have a part 2 and we can discuss that a bit more. So I just want to go through primary lesions. So primary lesion is basically a result of a direct pathological process. So you have different types of manifestations that can develop within the body. So when we're looking at macules, we know that they're small, flat, non-palpable lesions of less than 1 centimeter. This is an example. This is a freckle. Then we have a patch, which is a bit bigger. It's more than 1 centimeter. And these are typically your cafe au lait spots. Then your papules are small, elevated, less than 1 centimeter. Examples of this is a wart. Then you have a plaque, which is basically more than 1 centimeter. And here we're looking at psoriasis. They're generally slightly elevated, not as elevated as a larger papule. And then you have a nodule, which is basically a small bump, less than 1 centimeter, with significant deep component. So basically what they're saying is there usually is a deeper component, and usually only find this when you palpate it. An example of this is technically an enlarged lymph node. Then you come to a tumor, which is a large bump of more than 1 centimeter with significant deep component. So as well, it needs to be palpated. The nomenclature of this basically is, tumors are very much related to carcinomas, but not really. Like xanthomas don't generally follow that type of, carcinoma type of classification with regards to tumors. Then vesicles basically are small fluid-filled containing lesions of less than 1 centimeter. An example of this is a blister, and then your larger blister is a bulla. So these are just basically an illustration of what I just mentioned, where you have your macule and patch or your tumor, and there's your papule, where they did say there is a bit of elevated lesion of less than 1 centimeter, then a plaque, nodule, vesicle, bulla, pustule. This will be on Prof. Musa's site, so you guys can go ahead and also have a deeper look. So secondary lesions develop from an affected epidermis, excoriated, inflamed, where you have manifestations such as scarification, scaling, crust oozing, and basically fissure, erosion, or ulceration. Okay, so let's get to the juicy parts of this presentation, where you guys are going to interact a bit more with me. Okay, so if you all can have a look at this lesion. So I just want to give you guys a little bit of a scenario behind each picture, and I'm going to go on to questioning. So a mother brings in her child with the following scaly rash in the flexural surfaces, which is very itchy. Of note, the child was diagnosed with asthma last year. So what is your diagnosis? We are looking at symptoms and signs, and we're also going to basically be looking at treatment. Does anybody want to start off with the diagnosis? Yes, Roland. Roland?
Roland, you should be able to speak now.
Okay. Yes, Shavania. I think that for me, I think that the diagnosis is eczema, and yeah, symptoms is that the rash that we can see. You've spoken about itchiness, and also pruritus, and yeah, and then the treatment, it will be Mylocort that that can apply, yeah, there. You can also give betamethasone, and a soap, and you can use as emollient, and also you can, yeah, I think that's it. I think so.
Yes, thank you, Roland. Yes, that's absolutely correct. So if we're going to look at that, sorry, I should not change my, okay. So if we're going to look at the answers, so you are correct in that the diagnosis is atopic dermatitis, which we commonly call eczema. The symptoms and signs, basically, you have an itchiness, dry red skin, with small bumps that can occur on the cheeks, forehead, and scalp. The itching is first, and that is generally followed by a rash. So that's how the disease progresses. Chronic eczema may appear as areas of thickened skin, so lichenification. So also it's important to remember that these basically occur in the flexural surfaces of the hands and legs, face and neck. You can also have secondary bacterial infection that can occur, and it can then result in impetigo and pustules. It's also very, very important to remember that you need to look out for family history of asthma, hay fever, or other atopic dermatitis. And in babies, it occurs generally at 3 months of age. Patients are more susceptible to herpes simplex in the background of an eczema. Dr. Petkova, I see your hand is raised.
Yes, I'm not sure if you can take the questions now or we can do it afterwards. I don't want to interfere with your presentation, maybe. What do you prefer?
Thanks, Dr. Pekova. My presentation is actually more interactive based, so every single category is questions. So I'm going to be doing pictures and scenarios, and then basically getting input and giving answers based on what people have said.
Could you please go back to your slide there with the picture?
Yes.
To describe it furthermore, there is also an infection superimposed on that.
Yes.
Eczema, and also I think it's fungal infection as well.
Yes.
I'm not very certain if that might be also some signs of impetigo, because I can see that it's inflamed and there is maybe pussy lesions, but the picture is not very clear. And if I enlarge it, zoom it a little bit, it doesn't show me exactly what is going on there. But yeah, and that is also where is a lot of itchiness. What the skin, what exactly is happening with the skin when the patients start itching a lot on that place? What we call that condition?
So I know they basically say that there could be a lot of excoriation and thickening of the skin after scratching, because due to the chronic inflammation after scratching, it causes thickening and lichenification. Yeah, and plaques can also develop.
Yes, also you can see hyperpigmentations.
Yes.
And what is the lichenification of the skin? What is that?
So it's basically thickening of the skin due to chronic inflammation that happens with.
Yeah,
with the
I think we have it on that picture, although
Yes.
now we cannot touch it. All right.
Yeah.
Thank you.
Yeah, I'm sorry. I think when I even presented this picture and enlarged it, it made it even worse on this presentation. Because in the normal slides, it was a bit more clearer, but when I enlarged it, I see it's a bit more unclear. So I'm sorry for that. Okay. All right. So going on to treatment. So basically, you're non-pharmacological. You're going to basically, advise your patient to avoid direct contact with woolen or rough clothing or anything that could cause irritation to the area. Then also avoid overheating, which could further cause irritation, inflammation. Then trimming fingernails is very important, primarily because if they do scratch with unhygienic hands and fingernails, it could predispose them to bacterial infections. So we do not want that, and we do not want to complicate their condition. Also to avoid soap on infected areas and practice good personal hygiene. So pharmacological treatment is technically a stepwise approach in which, in step one, you want to avoid soap by using a soap substitute. So an example of this could be like an aqueous cream or emollient ointment, where you advise them to apply it, during baths. And then if that doesn't work, or if there's no response within 7 days, we move on to step 2, where we then introduce a hydrocortisone 1% cream twice a day for 7 days. And then you use sparingly to the face, avoid contact with eyes. If there is a response, then you gradually stop it and go back to step 1. So in most of these steps, you'd notice that if there's generally no response in 7 days, or if there is a response, you do reduce and you go back to step 1. So the mainstay of treatment is just to try at most to go back to step 1 and try and avoid these harsh steroid-based ointments, which could cause skin atrophy in the long run. So step 3, if there's no response within 7 days, or there's more severe eczema after step 2, then you can add a betamethasone ointment, 0.1% for 7 days, or any other potent topical steroid available at your facility. So that's a stepwise treatment. Then for itching, only children above 2, you can give them chlorphenamine, or if itch is not well controlled, then you can switch to cytarabine. And you refer if they are not improved within 2 weeks, or if it's extensive, and children maybe needing something stronger than a 1% hydrocortisone cream need to be referred, and if they're not responding to step 3. Dr. Petkova, your hand's raised.
Yes, sorry.
Yes.
I hope I'm not irritating you.
No, continue.
Okay, I just want to add to the that step of where you can use non-pharmacological stuff. You need to educate the patient. One thing is that children need to be, the nails on the fingers need to be cut very short, so to avoid scratching and superimposing bacterial infection, as one of them is impetigo, as we saw that the picture already was with the superimposed infection. The other thing which I can emphasize on is you need to tell the mother what exactly the mother can restrict for that child to avoid eating and drinking, like all the cold drinks which are containing colorants. They have to be stopped. So the very common juice which our children drink at school, it's Oros. So the Oros is full of colorants. That is one thing you need to tell the mother. Peanuts, very sensitizing food. Eggs, strawberries, so fish from the can. You need to educate the patient what can provoke that eczema to become worse. Then the last thing I want to say, you mentioned about aqueous cream. There is on the market so-called Epizone, E, which stands for emollient. So they can, patients can buy that aqueous cream. It's called Epizone, and it's E, not A, because A, it stands for something else. So that aqueous cream is designed to wash with, to wash your body, and you practically take a shower with that instead of using soap. It has dramatic effect on the skin. It can improve the eczema, I would say maybe 80%. And if all the other food which contains colorants can be restricted, maybe the atopic eczema can disappear completely, and the child can grow it up totally. Also, the soap and the washing powder which patients using, it's very crucial. They have to do a trial what exactly, which soap or which washing powder is not irritating them too much. Also, remember that some particles of the washing powder or the soap remains even after washing and drying the clothes. It remains on them. So that's another thing. And the last thing I want to say is what is the underwear. This kind of children need to wear cotton-made underwear, because with the all these polyamide or whatever artificial materials, they can scratch even more. Thank you.
Thanks, Dr. Pekova. Yes, I think you raised really important points about non-pharmacological ways, and it's very important because the social aspects and things that they do when they get home ultimately really do affect the way that they respond to treatment as well. Okay, so moving on to the next slide. So this patient basically is a 3-year-old brought by the mom, and she basically complained of multiple lesions on the leg with a crusty yellow exudate. So what is your diagnosis and causative organisms and treatment that you guys would institute on this patient? Is Anne here? I'm going to pick on Anne.
Shavania, I was thinking the same thing. Anne is here.
Is Anne here? Anne, if you could please answer for us.
I'm driving. I'm not looking at the screen. Sorry. I'm listening, but I'm driving home from work. I just left the hospital. Sorry. Give me a few more minutes, maybe 15 minutes, then I can.
Okay. Anybody else wants to maybe take a
Shavania, is this a single lesion or the child has it everywhere else?
So as I said, it's a multiple lesions on the leg with crusty. We're just showing you one, but there's this crusty yellow exudate on the other lesions as well.
Now, for me, I think that if you have many of them like that, it can. I'll give a differential. It could be in impetigo, and it could also be just bacterial dermatitis. And the germ could be maybe Staphylococcus or something like that, yeah.
Yeah. And your pharmacological or treatment?
My pharmacological treatment, first of all, will be like we need to go with, non-pharmacological. As you mentioned, we need to educate the patient about hygiene, and also we need to make sure that there is no one else at home who is having the same lesions, or at school, for example. And trimming the nails will be very, very important. And also, this can be also probably contagious. So pharmacological treatment, I will ask obviously for allergy, and then I think that I'll go with flucloxacillin or cefuroxime. But flucloxacillin, I think, is the one that I will be using. And also, if they are like they turns up to burn or wound, I think I'll clean them with normal saline and do even a dressing with povidone or Bactroben. Something.
Yeah. Thanks, Roland. I see there was another hand raised.
That's my hand.
Okay.
I think I see Dr. Petkova's as well. From my side, I agree with Roland. I think bullous impetigo as sort of non-facially distributed. And then, interestingly, so topical chloramphenicol or fusidic acid is quite effective. I mean, interestingly, when we think of something like post-streptococcal glomerulonephritis or rheumatic heart disease, we most commonly associate it with streptococcal pharyngitis, but the streptococcal skin infections actually have a higher association with post-streptococcal glomerulonephritis. And so the strep pharyngitis would cause primarily an ASO titer elevation, whereas the skin would cause anti-DNase B titer. Yeah, just for interest sake.
Thanks, Shane. Yes.
Dr. Petkova, I see your hand is up.
Yes, I agree with you. That is blisters around, and it's an impetigo, and you can see it's very widely spread erythema around the lesion. And also you need to consider if the lesions are closer to the joints, to consider to check if there is no problem with the joints as well. The best treatment for impetigo is Bactroben. Unfortunately, Bactroben is out of the EDL book, and it's not available in our clinics in the pharmacy, which is very pity. It used to be a quick solution for impetigo to be treated with Bactroben. Thank you.
Thanks everybody. So yes, so it is impetigo of the bullous form. Clinical features basically starts as a blister containing pus. It becomes eroded and causes a honey-colored crust, which is very characteristic of impetigo. It can start on the face, buttock, and then spread. And you're typically going to refer if there's no improvement after the second dose of antibiotics. So the causative organisms, as Roland has said, is basically you have streptococci or staphylococci, most often secondary to other infections such as scabies as well. So you can have underlying scabies, an insect bite, tinea capitis, or even eczema. So any breakage in the skin can predispose you to this type of infection. So non-pharmacological, as you said, good personal hygiene, trim fingernails as well. And you can also wash and soak the sores to remove the crusts that do develop. Then pharmacological, according to our EDL, so they basically advise us to use povidone iodine, 5% ointment or 10%. And you apply that every 8 hourly. Then antibiotic treatment in children of less than 7, you would use cefalexin, 12-25 milligrams per kg per dose, 6 hourly, or you can opt for flucloxacillin, just depends on what you have in stock, 12 to 25 milligram per kg per dose, 6 hourly. And in children more than 7 and adults, you can use cefalexin 500 milligram QID or flucloxacillin 500 milligrams QID. Then in penicillin allergies, you can use zithromycin. So I want to just review now. So this patient comes back after 7 days. And now this patient's got a urine dipstick of 3+ blood. The appearance of the urine is very dark. Urine MCNS that you did on the patient comes back. There's red cell casts, granular cells, and culture is negative. They have positive anti-streptococcal O titers. And then the patient is now edematous, mostly on the face, fatigue, and reports a decreased need to urinate. And the patient also plots as hypertensive on pediatric hypertensive chart. So what is your diagnosis and of this patient currently? Shane, I see your hand is raised.
Apologies, I raised it by accident. I saw there was another hand raised.
Is there another hand? Yes.
Mengu.
Mengu Mpele.
Hi, Mengu, you should be free to speak.
Okay, is there maybe another hand raised?
Matthew.
Shavana,
Yes, yes.
I don't know why we are going from dermatology to something. It looks like nephritic syndrome, but now I don't know how can we get it there. How can we get there?
So yes, Roland. So is there another hand raised? Sorry.
Those that have raised their hands, what I do is I allow you to speak from the coordinator's perspective. So once you've raised your hand, please feel free to unmute yourself and then you can add your voice to the conversation.
Hello.
Yes. Dr.
Yes,
Mbuka.
I guess that is post-streptococcal glomerulonephritis that is developing on these patients.
Yes, Doc, precisely. So we see it a lot in patients that have impetigo that if they come back with this type of picture, it's generally a post-streptococcal glomerulonephritis. So even though, yes, it is dermatology, but we've got to think of this in the background. So that's why I added this, so you guys can just have a bit of a broader perspective when dealing with these type of patients. And thank you for your answer. Okay, so moving on to the next patient. So the scenario is the mother brings in a patient, complains of cough, red eyes. She also reports that the child has tiny white spots like in the mouth, in the cheek. So what is your diagnosis, common presenting complaints, and treatment of this patient? Anyone want to, or can I maybe just continue?
Hi, Shavania's Anne.
Hi, Anne. Yes, we're waiting for you.
I'm back. Yeah, I think this is a suspected case of measles.
Yes, excellent.
And the lesions in the mouth is probably couplet spots.
Mm-hmm.
So this is a notifiable medical condition. If you suspect it or confirm it, you should notify it. And then the treatment is vitamin A supplementation. You can take blood for serology to confirm. And then basically, if a viral condition, so there isn't actually any treatment for it, it's more of expectant and observing, and then managing the complications if any results from it. And also because of the spread of the condition, you have to probably isolate this child for, I can't remember the specific duration of isolation, yeah.
Thanks.
Great, thanks, Anne.
I've got a question.
Yes, Dr. Pekova.
What is the most common complication of measles? Why are we so emphasizing so much on the measles?
So patients can develop, measles, pneumonia, meningitis. They can develop a lot of complications. So we want to treat it as early as we can.
Yeah, even encephalitis. Don't forget about that as well.
Yes, thanks, Dr. Kepova. Yes, it's very important to remember our complications, and that's why when we spot measles, we notify and we treat, we isolate as early as possible.
I think otitis media too.
Otitis media, yes. Okay, so as you said, the common presenting complaints, they can present as coryza with stuffy nose, conjunctivitis, a fever, cough, which is generally dry, Koplik spots, it's dry unless they've developed pneumonia already. Then Koplik spots, which is basically what we spoke about. So you'd see a white spot on a red background. It generally fades after 3 days, the rash, and it leaves a temporary pigmentation. So as Anne said, we need to stabilize the patient. If they're coming in with complications, we need to do airway, breathing, circulation. If we need to establish an airway, we need to do that. Then isolate and notify. It's very important to do that, especially in our PHC facilities. Then you're going to give the patient antipyretics to control the fever they come with, and we generally give them paracetamol at 15 milligrams per kg. And then administer vitamin A. So it's basically 2 doses for all children with suspected measles. The first dose is given immediately, and the second dose is given after 24 hours. And then no prophylactic antibiotics are indicated at this stage. Of note, it's also important to look for IMCI danger signs, as we said in the initial assessment, or signs of shock that could also accompany the diagnosis. And you're also going to look for other complications, as Dr. Pekova highlighted, or any signs of sepsis, and nutritional status as well is very important. We're also going to look for stigmata of HIV in these patients. Okay, so in the following patient, the mom brings in a 7-year-old and states that the 3-year-old in the household also has the same issue. She said it's very itchy and causes them not to sleep at night. So what is your diagnosis, causative organism, and treatment of this patient? Yes, I see a hand raised.
Yeah, Shavania, it's me. Yeah? It's me, Roland.
Yes, Roland.
Yes. Okay. Based on the localization of the lesions, I'm thinking of the fact that it's very itchy. I'm thinking about scabies, and the treatment should be, first of all, non-pharmacological treatment, which should be to insist more about hygiene. This is very highly contagious, and trimming the nails as well. And I think that the treatment should be benzoate, I think, that you apply over the night, and then you wash out the next day. And also the patient needs to use his own toiletries, some things like, and even the sheets at home, things like that. Yeah, that's what I can say about this one.
Yes, excellent, Roland. Yeah, so I think you've highlighted the important points, and that's some things we should look out for. Before I go to the answers, I think there was another hand up. I'm not sure if anybody wants to add more to what Roland said. Okay, so of note, usually, as Roland said, the distribution, it generally comes into the skin folds. It affects more than one person in the household, and it's usually accompanied by intense itching. And as for the secondary infection, it's also caused by scratching of unhygienic hands and long fingernails. So as you say, the diagnosis is scabies. The causative organism is Sarcoptes scabiei. So the treatments basically, we're going to basically treat all close contacts of the patient, wash all clothes and linen in boiling water. Remember the scabies parasite, it dies under temperatures above, I think it's 40 degrees. So you want them to basically wash all their clothes in boiling water and then dry the bedding and clothes in direct sunlight, which kills the parasites. You also want to put the actual beds in direct sunlight, as the parasites could have also gone into the mattress. And then you cut fingernails, wash your hands regularly, and put on clean wash clothes after medication is applied, so as to prevent, a reinfection and recurrence of the scabies. So in pharmacological treatment, adults and children over 6, we're going to give a benzoate, as Roland had highlighted. It's a 25% lotion, and you basically apply it on the entire body on 2 consecutive days. You leave it overnight and you wash it off the next day. If there's no response, then use permethrin 5% ointment. And in children less than 6, you can use a permethrin 5% ointment. Dr. Pekova, please add.
Yes, I just want to add that the linen needs to be not only washed, to be ironed, and especially on the folds where are the stitches of the linen, it needs to be emphasized the ironing there. Thank you.
Thanks, Dr. Pekova. Yes, that's very important. So the heat is something that needs to be emphasized, because actually the parasite dies in heated environments. Okay, so we've got this next kitty. So Granny brings in her granddaughter with the above rash. She says that most of the children in the daycare have developed this rash, and it is very, very itchy. So diagnosis and treatment. Roland, yes, you're on fire today. Roland? Anybody else wants to maybe comment? No? Okay, so I'm just for the sake of time, I'm just going to run through it. We'll discuss a few conditions. If anyone wants to ask stuff, I'll go for.
Sorry, did you
Oh.
did you listen? I was not on mute. Huh? Did you?
You might have been on mute. You might have been on mute.
Okay,
So,
no, I was saying that it looks like chicken pox.
Yes.
And the way you can see the lesions on the face and the distribution, and if you enlarge it, you will see that it's like umbilicated somehow there. And so the treatment will be isolation, hygiene as well. We need to trim the nails as well, and also it is very, very contagious, as I said. So we need to isolate. So on the pharmacological treatment, first of all, we need to address the itchiness. So we're gonna give, we're gonna apply calamine lotion. And if the child is above 2 years, we can give chlorpheniramine or allergics. And also, if the child came within 2 days from the beginning of those lesions, we can also give acyclovir and acyclovir, and yeah, that's what we can do.
Thanks, Roland. Yes, exactly. So this is basically chickenpox caused by varicella zoster. And treatment, as we said, non-pharmacological, you want to isolate, avoid hot baths, personal hygiene, and trim nails. If there's a mild pruritus, you can use a calamine soothing lotion. If there's severe pruritus, you can consider using an antihistamine. Antiviral therapy is generally only indicated for immunocompetent with very complicated varicella that usually involves, the eye and other areas of the body, and for immunocompromised patients. Initiate as early as possible within 24 hours of eruption. Then you want to also consider acyclovir 20 milligrams per kg per dose 6 hourly for 7 days. Max dose is 800 milligrams. Acyclovir IVI can be given in severe cases or where oral can't be tolerated. And as Roland said, prophylaxis, basically post-exposure prophylaxis, must be given to neonates whose mothers develop varicella 5 days before delivery or 2 days after. And varicella immunoglobulin can be given within 96 hours of exposure, or you can also consider giving acyclovir. Okay, so with this patient, I'm just going to run through. This is known as cradle cap. It is also known as seborrheic dermatitis. It's a kind of form of dandruff in newborns. It generally resolves on its own within a few months, but you can assist by washing with mild shampoo or using oils to soften the crusts. So it's pretty common, and we see it a lot in primary healthcare. So going on to adult skin conditions, we're going to be looking at allergic infections, autoimmune hair and nails. So let's just look at this scenario. So both of them are technically representing a hypersensitivity reaction. And I want to basically ask you about the manifestations in each. So picture A versus picture B. What are the manifestations of your hypersensitivity here in these patients, and how do you technically treat both? Okay, so I think for the sake of time, I'm just going to run through it. Oh, is
Okay,
somebody there?
I was going to try.
Okay, go on.
Shavania, so you have a background of erythema, and it's often an acute onset, maybe minutes to hours after they can get sensitized to something, maybe a chemical or food or an allergen. And then you have the hue flare reaction, as you can see quite clearly in picture B there. And they often respond very well to antihistamines or mast cell stabilizers.
So yeah, so exactly. And so the thing is that contact dermatitis, and the picture A is basically contact dermatitis. You see these small papules versus the hives, which basically start as papules and they coalesce. So picture B is typical of hives. So technically, the treatment for both is very similar. For contact dermatitis, you want to avoid the causative substance. So the guy in the first picture was wearing the ring. It might have had a nickel or substance in it that could have been causing him to have an allergic reaction. Then topical steroids can help decrease inflammation. And if a large area is involved, then systemic steroids are preferred. But then you should also consider using low-dose topical steroids to avoid skin atrophy. Then treatment for B is basically it should resolve on its own, but if it lasts for longer than 3 days and it covers a large surface area or caused by an unknown allergen, then a dermatologist should handle the case. And if they are accompanied by severe signs of anaphylaxis, then emergency care must be instituted. So there are generally two types of allergic reactions. There's the allergic versus irritant. So allergic reactions basically are delayed response after a foreign substance comes into contact with the skin. An irritant is basically, it's non-immune modulated, but it's basically when an irritant comes into contact with the skin. And it could cause this in every person. It's not that you're allergic to it, it's just that the substance is irritant for the skin in general. So other treatments for hives include the use of an antihistamine, for mild cases, corticosteroid topical ointments, omalizumab, which Anne mentioned, for chronic allergic reactions. And then it's also very important for patients that have these things and have accompanied life-threatening complications. It's important to use an EpiPen for them and let them keep it and counsel them on how to use it, and that they should inject it into the thigh if they have any complications. Unfortunately, an EpiPen is very expensive and a lot of people cannot afford it. So if you do come across a patient who does need it, you can even withdraw some adrenaline into an insulin syringe and let them keep it in a case, and then they can inject themselves if they are having a very severe allergic reaction, because EpiPens are really expensive. I think there was another hand up. Matthews? Dr. Pekova?
For the first picture, you can use also this epison E, which I mentioned. Keep in your mind, this could be a chemical or also gloves. Some people use gloves to wash their dishes with. It could be a reaction to the gloves as well. The second picture is urticaria. This is an allergic reaction to some foreign antigen. So it could be fish, or it could be strawberries, peanuts, eggs, whatever you name it. So you need to distinguish between the first and the second condition. And the second condition, normally we have to give allergics to the patients, and Phenergan injection, don't forget. Thank you.
Yes, the EpiPen is the adrenaline injection that we generally do give to patients with the urticaria or / hives. Roland?
Yes. Actually, just to complete Dr. Petkova about urticaria, also, I don't know if the EDL still advise the use of this cream, mepyramine maleate. Mepyramine maleate, usually it used to work very well with urticaria. Yeah.
Okay, I haven't seen it on the EDL currently. They just talk about calamine and they talk about chlorphenamine. Okay. So what is
Sorry,
the
Shavania, just in the meantime, for those attending, if they could just fill out the poll while you finish. But just to answer Roland, is that it's no longer in the EDL, so it is just the medications as you've advised.
Yeah, just the chlorphenamine and the calamine lotions under.
Okay, thank you. Thank you, Shane.
Yeah.
Thank you.
Okay, so this is basically known as target lesions. I'm just going to answer for the sake of time. It's basically a type 4 hypersensitivity reaction. It's commonly known as erythema multiforme. The onset is gradually within 24 to 48 hours. Just want to change my slide. And the causes are generally due to penicillin-based antibiotics or herpes simplex or mycoplasma pneumonia. And then the treatment is basically self-limiting, but you refer if systemic symptoms are affected, systems are affected, and if there's mucosal involvement or if you are unsure of the diagnosis. So the common allergens to look out in primary care include pet dander, pollen, as Dr. Pekova also mentioned, detergents, fragrances, plants as well. Plants can also cause many allergic reactions. Foods such as nuts, fish, canned foods as well. It's very common. Certain medications, especially if patients have been started on new treatment. Dust is also very important. It's not just the dust you see. Dust hides in curtains. It hides in bedding. So also with regards to patients washing their bedding and stuff, it's very important, and their curtains. Mold and nickel found in jewelry as well. So looking at this slide, so this is basically a 54-year-old male that comes to you with a swollen tongue. He states to have started high blood pressure medication 1 week ago. He also states that medication that he feels caused is Pharmapress. So just to run over this quickly, this is angioedema. The reason why I included it here because it does represent generalized body swelling, and it can be sent to dermatology. So medications that are generally causes the issue are NSAIDs, ACE inhibitors, or angiotensin receptor blockers, antibiotics, brufen, and there's also certain types of food and insect bites. And you technically want to remove the causative agent, and you're going to treat if there's laryngeal edema or airway edema, and establish a definitive airway. And in these patients, you administer IMI adrenaline Immediately hydrocortisone, cytarabine, promethazine, if there is airway obstruction. So if we're looking at this patient, we see a lot of hyperpigmented lesions, blistering lesions. You also see lesions in the mouth, on the eyes as well. So this is a generalized multi-system involvement. So the background of this patient is that he's a 25-year-old male that comes complaining of this rash that started 2 days ago. And he states that he sought help from a doctor after developing bipedal edema and hypertension. The doctor gave him Lasix to treat the condition. So Lasix, furosemide, keep in mind this as we're going through the answers. So the diagnosis of this patient is technically a Stevens-Johnson syndrome. It's basically a life-threatening acute hypersensitivity reaction involving the skin and mucous membranes. And common causes include like your sulfonamides, furosemide, NNRTIs, nevirapine, anti-epileptics such as phenytoin, phenobarbital, carbamazepine, lamotrigine, allopurinol, and laxatives. And the treatment is technically following the same as toxic epidermal necrolysis, which is in the next slide. The difference between both is that toxic epidermal necrolysis usually involves more than 30% of the total body surface area, versus Stevens-Johnson's, which involves less than 10%. So just of note is that the cutaneous lesions start as dusky red lesions and progresses to confluent lesion with epidermal necrosis. And there's generally large blisters that develop, and those rupture, and those cause exposed and denuded skin. That's why these patients need to be treated in isolation, because the first layer of their immunity is gone. It's technically like being burnt. So mucous membranes usually are involved, and there's also multi-organ damage, which we must keep in mind due to the circulating increased cytokines. So if we're looking at this patient, as we can see, there's blistering, there's skin peeling, there's erythema. There could also be a bit of a bacterial infection going on here, superimposed. So this is basically what we looked at now is a toxic epidermal necrolysis. It's generally due to the medications that I listed above in the Stevens-Johnson's section. So the treatment is technically to stop all medicines as quickly and safely as possible. And if we need to taper it down, then we need to do that. So the aim of the treatment is to prevent complications such as dehydration, sepsis, halting also the hypersensitivity reaction. We also don't want to cause hypoalbuminemia through the loss of the first layer of the skin and third space losses as well. We don't want hypothermia, and we want to prevent a high cardiac output failure and adhesions or scarring. So it's vital for us to monitor the vital signs, examine daily for infection, do blood cultures if fever persists, or if there's a suspicion of an infection. The patient should be ideally nursed or isolated in ICU or high care. The dressings we can use, you practice skin hygiene. Daily dressing should be done, and it should be bland, non-adherent. So we're looking at things like Bactigras, things like that, anything that's not going to stick to the skin. Then the mucous membranes, if we're looking at that, we're going to do a 2-hourly mouthwash, monitor the eyes, oral and genital areas for scarification and infection, encourage ocular and genital care, and encourage fluids and lukewarm foods, because we don't want to cause further irritation and burning within the mouth. Then the medications we generally use, steroids aren't generally indicated. Antibiotics indicated only if blood cultures come back positive. We don't prophylactically treat them for superimposed bacterial. And then provide good analgesia because it is very painful for these patients. So it's very important not to start them on antibiotics prophylactically, because they can also develop an MRSA and have resistance to certain bugs. So we want to really avoid that. Roland, shoot.
Yes, Shavania, I want to know, is this toxic epidermal necrolysis, is this what they call a Liel syndrome, isn't it?
Sorry, Roland, I think you broke up on my side. Can you just repeat
No,
that?
I'm saying, is this what this is what they call a Liel syndrome, Liel syndrome, as opposed to Steven Johnson syndrome.
Elite or LEL?
Liel syndrome, Liel syndrome.
Liel syndrome.
Yes, Roland, I think that's
Yes,
just a,
yes.
a sort of colloquial name, but more commonly referred to as TEN.
Yes, TEN.
Okay, okay.
Okay, so just moving on, I included this because it is a skin infection. So this is basically, we're looking at a cellulitis here of this patient. So the background is that it's a 69-year-old female who sustained a cut on her leg after jumping out of the taxi. She presents now to you with these lesions on both the legs. So technically it's a cellulitis. And risk factors are any condition which weakens your immunity. So shingles, eczema, cracks in the skin. And it's commonly caused by streptococci or staphylococci. And it's associated with a lymphangitis, or you can have lymph node involvement as well underlying the infection. So non-pharmacological, you want to elevate the limb and you want to also encourage mobilization. We generally treat them with flucloxacillin per os, 500 milligram per os 6 hourly for 5 days, or zithromycin in severe cases. And you refer if it's very badly or poorly controlled, or it doesn't respond to treatment, or it's very extensive, or if there's an MRSA that you suspect. And then associated features can be a fever, tachycardia, tachypnea, hypotension, chills, shock, delirium. And of course, recurrent cellulitis also must be, and poorly controlled diabetics as well must be referred. So in very severe cases, we opt for using IVI antibiotics. I know that in Helen, we used the Augmentin generally to treat these type of conditions. Okay, so looking at this condition, if you look here, you can see pustules at the hair follicles, and that's very characteristic of this condition. So if you're looking here, you can see pustules at the hair follicle. It's basically an infection of the hair follicle, which we generally refer to as furunculosis. And then as your risk factors are things like malnutrition, diabetes, alcohol, your obesity, atopic dermatitis can also predispose you to that, HIV, primary or secondary immunodeficiency, and the carriage of an infected organism. So non-pharmacological, you want to avoid sharing towels, you want to warm compress, good personal hygiene, you want to wash or sanitize your hands regularly. You want to suspect MRSI, especially in long hospitalized patients that develop this, you can suspect an MRSI in this patient. And you only use antibiotics in severe cases where carbuncle or furuncle develops. And you avoid prophylactic treatment and only treat after obtaining a pus swab in these patients. So the next patient, if we're looking here, we can see these comb domes that have developed on the patient's face. So the background here is that she's an 18-year-old female, came complaining of these lesions on the face. So the treatment here, or the diagnosis, sorry, is basically acne vulgaris. It's caused by inflammation of the hair follicle leading to comb dome formation. And it's basically caused by obstruction of the sebum glands, then leading to keratinization and follicular plugging and production of these comb domes that develop from propione bacteria. That's the main bacteria that's behind acne vulgaris. So the distribution is the face, chest, back, and more common in adolescents. So we advise patients not to squeeze the lesions and avoid greasy products or excessive facial washing, which could cause like a rebound reaction and cause them to develop much more comb domes or whiteheads and blackheads. Then with mild acne, you can basically treat with benzoyl peroxide, 5% ointment. And with non-inflammatory acne, you can use a topical retinoid to reduce the comb dome formation. So we use tretinoin. And then moderate inflammatory acne, I use benzoyl peroxide 5% and doxycycline. So these are the grades of the acne. This slide will be uploaded on Prof. Musa's site, so you guys can have a look at this when you have some time. I think there was a hand raised.
Shavania, yes, that's mine. I think we are up on time.
Yeah.
And so fantastic slides and a lot of information. I think unless you have something pressing just for the sake of the members' time, we'll make the slides available on the group. And so we'll be able to access your slides there. Is there anything essential that you wanted us to cover or touch on?
I think we've gone through most of the urgent stuff that I think we needed to go through. And yeah, I think they can probably just read through it on their own once it's uploaded.
Perfect. Then happy to close. If we have any final closing comments from any of the panelists or group members. Otherwise, thanks, Shavania, so much for your time. Excellent presentation, and we'll make it available on.
Excellent presentation, Shavania. Thank you very much.
Thanks, Roland.
Please, we'll carry on our yeah.
Yeah, I'll continue it on our private platform.
Yes, please. I want you to finish this. Okay, thank you very much.
Thank you, Roland. Thanks for your participation. Okay. Thanks everybody for joining.
Thanks everyone, and we'll see you again next week.
Thank you.
Thank you, everybody. Looking forward to next week.
Thanks. Bye.